We want to kind of give you a sense of the context in Manchester. So we're going to start off with a little bit of information about what we think the need is in the city, a little bit around what our provider landscape is, so what services do we already commission for mental health care in the city, and then a little bit about strategy, direction of travel, and then moving on to sort of more information around the two services in question for this grant, which for us is improving access to psychological therapies, which we'll explain shortly, and then the other one is community mental health teams. And then even digging down a little bit deeper and then trying to give you some examples of the lives that people have who use those services to try and sort of stimulate some ideas around maybe what's a good way of using the grant money. So, the first two slides are just some sort of very high-level figures, stats really, around what the mental health need is in the city. The first slide is referring to some stats that comes from a new national report around mental health. There's a National Mental Health Task Force that's published in February 2016, a report which actually outlines a list of recommendations for how to develop and improve mental health care across the country. So this is just some very high-level information. There was oodles we could have pulled out, and if people want reference to that document, I can provide it afterwards, or we can send it around afterwards. But in essence, what these bullet points are saying is that there are many different types of mental health problems that people can experience. Nobody is excluded, and I know I'm talking to people who know this anyway, but it's just important to try and state the evidence, really, that no one's excluded from experiencing a mental health difficulty in their lives. And actually it starts to sort of highlight some of the impact of poor mental health on people's lives, on the economy. So, second slide is now drilling that down a little bit more locally. The reference here is the Joint Strategic Needs Assessment, commonly known as the JSNA, that local authorities have the responsibility to develop a JSNA. I'm not sure how frequently it is, but the one for mental health is from October 2014. Again, there was oodles of information and data that I could have pulled out, but this again is just some high-level information. There is a little bit of a trend. Manchester tends to experience things, or the prevalence is a little bit higher for many conditions and issues in Manchester compared to the national average. Okay, this slide is, and I apologise if it feels like there's oodles of information in these slides, so I'm not going to talk enormously in detail about them, but I just thought it might be helpful to get a sense of what we commission already. So, as I already said, North, South and Central Manchester commission mental health services collectively, and our overall budget for mental health last year, it's in fact changed for this year, but we're just focusing on, for the sake of today, it's much easier to give you a concluded figure for last year, is that it was around £104 million. And that, in essence, is our budget for child and adolescent mental health services, learning disability and mental health services. So, there are providers that I've actually not listed there, unless the slide would have been too busy, but just to give you the main areas. Manchester Mental Health and Social Care Trust is our main provider in the city of mental health services, and I think that's around 64% of our budget. They provide a whole array of different types of mental health services, but they include psychological therapies, the acute community and inpatient facilities, rehabilitation services from a community basis and from an inpatient basis, and lots of other things that I'm sure, and health and wellbeing services, and many more. We also have a budget for what we call independent hospitals. So there are some people who have experienced really complex mental health difficulties, and actually they require, the services in the city are not yet sufficient really in terms of a local contracted provision. So actually there were some people that receive placements in independent hospitals. I've already said that part of our budget is delivering CAMS. That's actually delivered by Central Manchester Foundation Trust, and they also provide our community learning and disability services. And then we also have a selection of contracts through the third sector. I've listed some of them there, so self-help services, survivors, the GADM, Lesbian, Gay and Bisexual Foundation, and Afro-Caribbean Mental Health Services, Age Concern, 42nd Street. There are more, but they're the main ones that we commission. We also commission what's called a first episode in psychosis service, and that's provided by Rotherham and Doncaster and South Humber NHS Foundation Trust. They don't deliver it in Rotherham, they deliver it in Manchester, but they are the provider of that service. And we also have contracts with other mental health trusts in Greater Manchester. So we actually buy activity for people who live on the cross boundaries around the city, so people who may live near Stockport, near Oldham, near Rochdale, is that we actually commission some activity from those other mental health trusts. Shall I just mention the City Council? Also, Manchester City Council have a budget for mental health. That's around 16 million last year. And in essence, what the City Council, Michael will correct me because Michael's the Commissioner from the City Council, is social care, which is provided by Manchester Mental Health and Social Care Trust. And they also have budgets for individual personal budgets and housing-related support services. So, next one. I've got 2 slides to try and give you a sense of what the strategic context is in the city from a commissioning perspective. That's not just commissioning, it's commissioning and providing. There is, as part of the Greater Manchester Devolution Programme, every locality within Greater Manchester has developed and is developing their locality plans. The reason for me putting this in is that it's recognised that mental health is a really significant issue for the city and for the people of the city, and therefore the mental health section of the locality plan has really quite a strong place in the locality plan. And they're the very sort of headline information, but what we're aiming for is actually services that are effective, services that offer quick and early intervention, and that they're focused on recovery. A lot of our services over time, we've got some fabulous services in the city, but the mental health services, like lots of services, have evolved over history, and actually we need to have much more focus on all the services we commission actually result in good outcomes for people. And that might sound like a really obvious principle, and it is the right principle, but in terms of having that outcome focus in our contracts is not completely there yet. Improving access to psychological therapies it's one of the only mental health service lines we have, or provisions, that actually focuses and records what the patient outcomes are. Final slide on the locality plan. There are 3 pillars, sort of structures around the development of the implementation of the locality plan. One is that there'll be a single commissioning structure. In essence, at the moment, we have 2 commissioning structures in the city. We have, 2, maybe 3. Is that we have, the City Council has a commissioning structure and the CCGs have a commissioning structure. We're pulling those together and it will be one commissioning structure. One team. I'm sure people might have heard of the one team. It's a RAS. The principle is saying that any community service should be delivered in the same geographical configuration, and that all of those services should be integrated in some way for the needs of the patients. So we have got a slide later on that talks about what that configuration is, but it's in essence saying that services are either delivered on a 12, which is a 50,000 population, or they're delivered on a 3, which is a north, south and central configuration, or they're delivered on a 1, which is a Manchester configuration. And then when you think about Greater Manchester, then we go back up to a 10. Some services may be delivered on a Greater Manchester basis. And then a single Manchester hospital service. There's all work afoot around how the acute hospitals start working together. Big principle of the locality plan is that the funding longer term will be lower. And so part of the locality plan is how do you integrate and how do you try and deliver your services differently that still meet patient need effectively but within a lower budget. It's so significant. Moving into mental health. We thought we'd just put these 3 headers on because I don't quite know how much people know about the landscape and the current situation around mental health services in the city. There's 3 sort of bits to say, really. One is there is currently a transaction of services provided by our main provider, Manchester Mental Health and Social Care Trust, afoot at the moment. That's due to conclude in August of this year, or a preferred provider to be known in August. NHS planning guidance. It's what we have to listen to and take note of in all that we do as commissioners. For the first time, not the first time because it came in last year and maybe the year before, but it's growing in size, is what we're calling the parity of esteem. And this is what you hear in the news, a lot of the national news, is that there is now much more emphasis on mental health commissioning and the standards within mental health services, and how NHS England starts to kind of feed that down the tree is that they give us indicators, targets in mental health that we need to start achieving. And also we have to prove as CCGs that we have grown our mental health budget this year in line with the growth that the CCGs achieve. So it's just an important thing to say, really, because there is a lot of emphasis on mental health coming down centrally, feeding its way down to local CCGs and thus services. In terms of parity of esteem and the targets I mentioned, there are four. There's four now, but there's soon to be more. 3 of those pertain to what we call the improving access to psychological therapies. One of those is 15% of people should be accessing IAP services. 50% of those people should recover, and people should be waiting no longer than 18 weeks. There are targets, sort of smaller targets within the 18 weeks. So they're standards that you've probably heard already to cancer services, but they've never been in mental health services. So actually it's a really good thing. And also one more is that we have a new standard for first episode in psychosis. People who are thought to have a first episode psychosis should be referred and seen within 2 weeks, or allocated a care coordinator within 2 weeks. So that's quite a stretching target. And finally is in relation to the parity of esteem, we've got the new indicators. CCGs need to increase their investment. The CCGs have actually secured a further £3.5 million, so there's a bit of a typo there, it's not 1,000. It's £3.5 million for the development of services to meet those new indicators. Persistent challenges, there are quite a few in the city that they're shared by all of us. They're not just, they don't belong to the provider, they don't belong to the commissioner, they belong to all of us, because we need to try and get a mental health system that works better. We need to make improvements in how we meet the needs of people with acute mental health distress in hospitals or in the community. That we have big delays in access to psychological therapies, which I'll tell a little bit more about. And we have a fragmented delivery of services across the city. This is not necessarily anybody's fault, it's just the way that services evolved over time, the historical services, and I think lots of individual workers in the services really try hard to collaborate and integrate, but actually to do it as a system is actually really quite challenging. There still is stigma for mental health, and also it's hard for people to leave mental health services. I think there's an understanding and acceptance in mental health services that people don't experience elsewhere, and that's problematic for the person who's experiencing the problems. It's problematic for the services because it reduces the flow. So in acute hospitals, you wouldn't necessarily expect to be there forever. There would be very much about you get the right intervention that meets your needs, and there would be a flow, and that's a real challenge for us in the city. Okay, I thought I'd better put this slide on because I wasn't sure how much people knew about improving access to psychological therapies. We all live and breathe it quite a lot, so we're quite familiar with it. But in essence, it was a national programme that came out, I think, it's more like 2009 and 2010, but in essence was I think money came from the Department of Work and Pensions over to the Department of Health, and it was basically to expand access to psychological therapies and not just mean that the only response to a depression was prescription. And it's based on an evidence base, so it's very much about offering people a psychological intervention in which there is an evidence-based recovery. When it first started out, it was very much a CBT-focused programme. Now, it's been expanding. Over the years, it gets bigger. They're starting to include more psychological interventions, and the blue box lists what they are. Also, as I've already said, 15% of people who are thought to be depressed and anxious should be accessing those services. For us, we think our prevalence is just under 89,000, and 50% of those people should recover. So, this is our current performance. I've already said it should be 15. We think across the 3 CCGs it's 9%, but it varies between North and South and Central. Recovery, we're low on recovery. It should be 50%, and 6 weeks, all the percentages are there. It's a very challenging area for us all. And I should say that this is an accumulative, it's a CCG target, it's not a provider target, it's a CCG target. And we have two providers of our IAP services, which both Sandra and Melissa represent, and it's in the cumulative figure. So why the grant? One of the reasons is that we actually weren't funding sufficient to meet 15% access, and also it's a very challenging programme. So we have the money now, and we want to invest the money as well as we can. I've obviously already said we need to improve access and recovery. But also one of the biggest points is that IAPT is evolving. When it first came out, it was about CBT, and a lot of it is around people having so many sessions of individual psychological therapy, and that still is right. But actually there is now flexibility in how those psychological interventions should be delivered. And I think the services really, and us, really want to work and understand the local communities more, so actually we can make sure that those IAPT interventions are accessible for people in different parts of the city. But that takes collaboration, it takes conversations, it takes relationships, hence our idea around the grant. That's it. And then I'm going to hand over to Michael. So, thank you.